Well, here we are once again in Foundations of Moral Theology. And in this module, we're going to be moving to the other end, if you will, of medical ethics. Last time we talked kind of bridging sexual ethics into medical ethics and looked at issues surrounding the beginning of life and the kind of moral status of embryos and IVF and all those sorts of issues. And so what I want to do then in this module is to really focus on the other end of life, right? And particularly look at issues surrounding care for those at the end of life. And then also even some issues really kind of after death in terms of treatment of bodies and organ donations and those sorts of issues. But before we get to those particular topics, I want to start by doing some sort of basic overview of Catholic medical ethics. And one of the things I will ask you to do for this module is to take a look at the official ERDs for Catholic healthcare institutions in America. So those are the ethical and religious directives, and those are documents, or a document, I guess, put out by the U.S. Catholic bishops to really kind of guide Catholic healthcare in this country in a way that is in keeping with Catholic ethics, Catholic principles. And so I'll ask you to look at just parts of that because the whole thing is actually quite large. But you'll see there, kind of put into concrete detail, some of the principles we're going to be talking about here in this module. And so when we talk about medical ethics, or how we care for the sick or the dying, not surprisingly in this class, again we're going to go back to natural law. And in particular I want to talk about the connection with some of the very basic fundamental principles of natural law. So as all natural law is rooted in these ideas, so obviously medical ethics are going to be. So the first of those would be that absolute value, that dignity of the human person. And obviously this is going to be relevant when we talk about medical ethics because we can never intentionally harm a human person. And that's going to be a basic idea, of course, in medical ethics. But when we talk about, well, what makes up a human person, we need to consider, again, from a natural law perspective, that the human person is this unique combination of body and soul together. And that both are kind of essential to who we are as persons. And again, this is obviously going to be important, right? Because that human dignity plus the essential nature of the body means that the way we treat the body is going to have kind of fundamental moral significance from a Catholic perspective, right? So just like it's going to lend a great weight and seriousness to matters in sexual ethics, the same is going to be true when we look at medical ethics. So what we do with the body is going to very much matter. But I think it's also important in this context of talking about medical ethics to look at the flip side of that as well, right? That we were talking about this ultimate human dignity or intrinsic value of the person, which certainly includes the body. But it's also important to remember that it is not limited to the body, right? It's not the body alone that constitutes the person. It's that unique combination of body and soul. And so when we're talking about the good of persons, or the proper care of persons, or the integral good or flourishing of persons, bodily health, bodily function is going to be part of that. But it is not the entirety. And again, that is going to be crucially important as we move down and look at some of the different issues in medical ethics, right? Because in our society, we encounter very often those who would go to either of those extremes. And in a lot of cases, right, we have people who kind of embrace both extremes at once, depending on the situation, right? So we are often told that the body isn't essential to a person's identity, right? That the body can be modified, the body can be changed in any number of ways. But that's okay because what really makes a person is their spirit or their mind or their will. At the same time, right, we have many people in our society today who would deny that there's any sort of immaterial aspect to the person, right? So that it is only the body that matters, only the body that has value. And I think you can see this implicitly in the way many people strive to prolong bodily life, really with no consideration for any other factor, right? That there is this obsession with the extension of bodily life in our society that I think is a result of a loss of belief in this dual nature of the person, right? Of body and soul together. So we'll get to some of those particular issues later on here in the module. But those are the basic things, right? Human dignity and this understanding of what constitutes the human person as body and soul. And then we can build from that, of course, all of natural law, and we've gone all over that, so we're not going to repeat those things here. One of the things I do want to run through here, though, before we dive into some of the more specific issues around end-of-life care, is a short list of some basic Catholic ethical principles when it comes to medical ethics. And again, you can find numerous different lists floating around out there. So this is just one example of, I think, a fairly standard example of the principles involved in Catholic medical ethics. And again, it's not only going to be Catholic medical ethics, right? There will be other medical ethics statements from either medical bodies or from other ethical systems or schools of thought that would be very similar. But this is just to give us some starting points in terms of the principles that are going to guide medical decisions, medical ethical decisions, right? So the first is a fairly obvious restatement of a basic natural law principle, and that is the principle of beneficence and non-malfeasance. It's kind of hard to say that without enough coffee in my system yet. But beneficence and non-malfeasance simply means, of course, that we are going to try to do good for patients and never do something bad for a patient, right? So we're going to do good and do no harm, right? Which is a standard part of medical ethics dating back for centuries and even millennia. So that one is pretty straightforward. A little more specific, right, is the principle of self-determination. And again, this is rooted in some of the basic aspects of natural law, right, that we've talked about before. And that free will is an essential component of the human person from a Catholic perspective. And this idea of subsidiarity, right, that we ought to allow individuals or small groups to make their decisions. We'll talk about that more in the upcoming course, but it flows out of this understanding of the value of the person is that we ought to allow persons or families or small groups as much autonomy as we can. And so this idea of self-determination is in keeping with that, right? That patients have the right to determine their own care. Now, of course, sometimes physicians, sometimes family are going to disagree with the decisions made by patients. But again, this value of the human person and this emphasis on the importance of free will is going to lead to this principle that people have the right to determine their care or to refuse care in certain situations. Now, of course, this can get complicated at times when there is reason to believe that a person is not competent to make those kinds of decisions. And that's, of course, a very large area of concern in modern medical practice, especially with dealing with very elderly patients who have different kind of mental impairments. And so there is, of course, a challenge there. And then if someone else is acting on the patient's behalf, they ought to try to act in a way that's in keeping with their wishes, their desires, if they were in a position to articulate them. And of course, this is also behind the push for advanced planning for one's medical care, right? So creating durable powers of attorney or living wills or those sorts of documents. All of those things are encouraged by Catholic medical practitioners, and the Catholic Church has no issue with those things, right? Because it is a way of carrying out this principle of self-determination. Now, of course, we could still say that there are certain choices that people might make that would be wrong, but we're still going to respect people's right to make those decisions, just like we allow people the ability, the freedom to make wrong choices in many other aspects of life. So self-determination is a key principle. Following that is this principle of integrity and totality. And so the principle of integrity and totality, is pretty straightforward when you think about it. The principle of integrity says that we ought to maintain the integrity of the body as much as possible, right? So one ought to have very serious reasons for violating bodily integrity. And that makes sense, right? Again, given that dignity of the human person and the belief that the body is an essential part of that. So don't be cutting off parts unless there are real serious reasons for doing that. On the sort of flip side of that is this principle of totality, right? The principle of totality says that you have to act for the good of the total person or the total body. And so this is kind of the flip side to integrity, which says that sometimes to maintain this principle of totality, or to follow it, we can in fact excise certain diseased parts or injured parts or systems in order to preserve the whole, right? So it's this focus on the totality or the overall health of the person is a key principle of medical practice, medical ethics. Next principle here on our list is the principle of informed consent. And again, this is a kind of continuation of that principle of self-determination, right? That if people are really going to be able to determine what is the proper care that they ought to receive, they need to be properly informed of their choices and of the various risks and benefits with different sorts of treatments. Of course, all of this is to the best of a person's ability, right? And so obviously medicine is not an exact science, right? That there are many times where one just can deal in probabilities. But to the best of a person's ability, they ought to provide information to patients and then proceed when they have informed consent of the patient, which ties in with the principle of truth-telling, right? That people have a moral right to the truth about their condition. And so if a prognosis is going to be fairly grim, a person still has a right to receive the truth so that they can make informed decisions about their care. And also this ties in a particular way for Catholics with the belief, of course, that death is not the end, right? And there can be situations one can easily imagine where you might not want to tell a patient that they're in imminent danger of dying because you're worried about the emotional impact that would have, and you would rather allow them the time to enjoy the remaining hours or days without that sort of looming over them. But of course, from a Catholic perspective, there is a great value in being able to prepare for death, right? To receive the sacraments, to prepare for that next stage of human existence. And so it is crucially important that we tell the truth to patients in those sorts of situations. And I've had in this course, very heartbreaking stories of students who've been in this course where doctors did not do that, right? Where they had a loved one who was dying very rapidly, but the doctor would not tell the patient and insisted that the spouse not tell the patient because they were afraid of the impact on the patient. And in retrospect, that was a very poor decision. And so it is important. Now again, of course, there is reason for prudence in this, right? One needs to do this in a way that is going to cause the least distress possible, but it is important to tell the truth so that patients can prepare themselves and can make decisions about how they spend their lives. And then lastly is the principle of confidentiality, which we are all reminded of on a regular basis if you ever receive medical care, because you have to sign various privacy and confidentiality forms, it seems, 2 or 3 times per medical visit. Now I exaggerate a little bit there, but not terribly much. But as much as this bureaucracy might have taken this idea in really frustrating directions in some cases, it is, of course, an important and valid principle of medical ethics, right? That given the value of the human person, given the essential nature of our body to who we are, having information about our bodies shared with people who don't have a medical need for it is a serious violation of the person, right? That it is a violation of literally a sacred trust, right? It is taking very intimate details of someone and using them for economic gain or for even educational gain or what have you, right? That if those uses are desired and valid, then you get consent for that. But we don't take the details of a person and share them without that person's consent, because that's a violation of that essential human dignity. So that's kind of one list of some of the basic principles guiding Catholic medical ethics: beneficence and non-malfeasance, self-determination, integrity and totality, informed consent, truth-telling, and confidentiality. And again, there are other lists, but those basic principles are going to show up in most of them in some form or another. And again, we could talk about all sorts of situations where those would be applicable. So before we get to some of the more complicated issues when it comes to end-of-life care, I did want to talk just briefly here about some fairly straightforward issues, at least from the perspective of Catholic medical ethics. And that would be the various different ways that people within medicine intentionally end an innocent person's life. And so from a natural law perspective, all of these different things are going to be clearly immoral. Now there may be varying degrees of culpability, but Catholic medical ethics is never going to permit the intentional harming of an innocent person. And ending a person's life is going to be, in every case, a harm. So when we look at the very kind of current issues of euthanasia and physician-assisted suicide, the position of Catholic ethics is obviously going to be in opposition to these, right? And of course, we can often hear this in many parishes, right? When we have the prayers of the faithful, it is pretty common, at least in this area, to include in there a prayer that human life will be respected from conception to natural death. And that reference to natural death is specifically aiming at the movement in our country and in other countries for increased access to or legality for either euthanasia or physician-assisted suicide. Now, just real quickly to kind of clarify those terms in case you're not clear on them, euthanasia is when a medical person, typically either a doctor or a nurse or something like this, administers typically a drug to end a patient's life, right? So that is a kind of active euthanasia, right? You are you're giving them someone which is going to cause death. And of course, euthanasia is legal and accepted in some countries and even in some states here in the United States. The Netherlands is a particularly well-known example. Switzerland, I believe, is another example of countries that have permitted euthanasia. And there are all kinds of articles and such dealing with some of the consequences of that. So that would be, euthanasia is actively administering something that ends a patient's life. Physician-assisted suicide is a little different, right? And that is when a medical practitioner provides the means and instructions for a patient to take their own life, right? So Dr. Kevorkian was a famous example of this, right? He would set up these machines that would administer lethal combinations of drugs, and then the patients would be the ones who would actually push the plunger or the button or what have you. This also comes up in much less sensational and much less complicated forms when doctors will prescribe patients a very large prescription of some sort of painkiller and tell them, right, well, you wouldn't want to take all of these at once, because if you were to do that, that would cause you to stop breathing and die. With the kind of implicit suggestion that if they just want to take their own lives, this is what they can do. And there's a whole range of different possibilities in there. But again, there are a number of states either approving this or considering approval of physician-assisted suicide. Now again, this is maybe a little more complicated in ethical terms when it comes to the morals of the medical professionals involved, right? Because unlike in euthanasia, they are not directly causing the death of the person, right? The patient is causing their own death, which of course is still immoral, right? You can't cause the death of any innocent person, including yourself. But that being said, in terms of the medical professionals involved, they're going to certainly fall afoul of the principle of legitimate cooperation if they are providing instruction, providing materials with a specific aim of a patient taking their own life, right? So this would either be formal cooperation or some kind of immediate material cooperation. When it comes to one of the challenging issues when it comes to this is what about the role of, say, pharmacists in states that allow physician-assisted suicide? And there you could have maybe cases of proximate material cooperation, right, where you are giving those drugs. Now, in some cases, you may not be aware of what you are giving the patient. You might be not as directly involved, maybe it would be remote. But one of the real challenges of euthanasia and physician-assisted suicide is that we are setting up systems that are going to involve far more people in this immoral act of the taking of an innocent human life than just the patient, or even than just the patient and a doctor or nurse administering a drug, right? Because of the nature of the modern American medical system, there are lots of other people involved to varying degrees. Now, of course, at least in previous years, right, there was a related set of topics that was not quite so clear when it comes to whether they are moral or immoral, right? So when it comes to the management of pain at the very end of life, there have often been situations where you could legitimately use the principle of double effect, right, where controlling a patient's pain may well bring them much closer to death, right? And there could be cases where one has to be very discerning in terms of what is the intention, what's the potential benefit and cost. So there have been cases like that. Now, I'm understanding that in contemporary medical practice, they're much better at managing pain without running that risk of causing death from too much morphine, say. And so hopefully that issue is not as common as it may have been in the past. But that's a very different sort of situation where you are not intentionally causing death, where you are treating pain, and as part of the treatment of pain, unintentionally perhaps increasing the chance of death. So from a moral, natural law perspective, those are very different situations. All right, so we've kind of covered the real basics here, right? We've talked about Catholic medical principles, ethical principles. We have talked about some things that are kind of clearly and always forbidden when it comes to the end of life. Now we need to shift gears a little bit and talk about one of the more complicated issues when it comes to medical ethics and particularly care for people at the end of life, right? And that is thinking about ordinary versus extraordinary care. Now, if you read some of the literature, some of the books from a few decades ago, there has been different terminology used about this. So ordinary and extraordinary tends to be used most commonly today, but you could also talk about these categories in terms of proportionate or disproportionate care. And so, yes, it's going to be immoral if you decide to intentionally kill someone to end their suffering. But there are lots of situations where people are very ill at the end of life that are much more complicated, right? And don't involve directly causing a person's death, but revolve more around issues of whether or not we ought to continue medical care, whether we ought to continue a certain sort of treatment, or whether we ought to intervene when somebody experiences an acute kind of crisis in their health. And this is where Catholic tradition has used these categories of ordinary versus extraordinary care. And in many ways, this is a particular medical way of thinking about and applying principle of double effect, right? That we're going to be assuming in discussion of ordinary versus extraordinary care that the particular acts being performed are not in themselves immoral, right? So if you were using, say, embryonic stem cells as a treatment and deciding whether it was ordinary or extraordinary, some of the issues we're talking about in regard to the patient would be more or less irrelevant, right? Because the act itself is immoral. You can't intentionally harvest material from unborn embryos and use it for somebody else's care, regardless of whether or not that care would be ordinary or extraordinary for that patient being treated. The act itself is immoral, right? So we're talking about situations here where our intentions are for the good and the acts themselves are not immoral. So how, though, do we make these sorts of decisions about whether to continue aggressive chemotherapy? Do we continue dialysis? Do we use a ventilator for somebody who is failing in their breathing? That's where we're going to use these categories, right? And so in very simple terms, the terms themselves are simple. It's the application that's the tricky bit, right? But ordinary care is simply care where the perceived or the potential benefits are proportionate to or greater than the foreseen costs or benefit, or not perceived costs or side effects or those sorts of things, right? So if I'm going to give you a treatment, it's not going to cause a great deal of pain, it is going to be economically affordable, it is going to not cause a great deal of mental distress or suffering, and it has a clear medical benefit for you, well, that's going to be an obvious case of ordinary care. I should give that treatment, right? And so if medical care is ordinary, then it is morally obligatory, right? So if a medical treatment is ordinary care, then I as a patient have a moral obligation to receive that care because I have a moral obligation to promote my own health and life, and the medical practitioners have a moral obligation to provide ordinary care because by definition the benefits are going to clearly outweigh any costs or side effects or suffering caused by the treatment. So that's ordinary care. So it's pretty easy then for you to guess what extraordinary care is going to be. Right? Extraordinary care is going to be treatment or care that doesn't meet that sort of criterion. Right? So these cases of extraordinary care would be cases where treatment has perceived costs that are not offset by the perceived benefits, right? So this is going to be a situation where there's a great monetary cost, right? And of course, this is a big bugaboo in talking about medical treatments today. But medical or economic costs of medical treatment is a moral or ethical factor. And in this world, we do not have infinite resources. And so it does matter in terms of thinking about the morality of care what it's going to cost, and ought we to expend huge amounts of money on treatments that have very minimal or very questionable benefits. And so fiscal cost is going to be an issue here in extraordinary care. But more directly, or perhaps more pertinently in many cases, are questions of pain, discomfort, distress to patients and to family. All of those things are going to be issues in extraordinary care too. So if you have a treatment that is going to be expensive or is going to have lots of distressing, painful side effects, that could very well be a basis for determining that a particular type of care is extraordinary. Right? You also have to look at the perceived benefits. Right? So if a treatment is going to restore a person to a state of health where they can really enjoy a flourishing life, then there would be a great deal of costs and pain and suffering that would be justifiable. However, right, you could have a same sort of set of costs in terms of economics or pain or side effects, and if the perceived benefit from it was going to be very minimal, maybe a few more days of life or maybe a few more weeks of life at the end of a long chronic illness, that same treatment may not be proportionate, may not be ordinary or morally obligatory in that situation. Right, and this is, I think, obviously true, but it is also a case where many people become uncomfortable and would really want there to be a much clearer, easier answer for these sorts of cases. But this is just the nature of human life, right? And we can see this from principle of double effect, which dates all the way back to Thomas Aquinas at least, and recognizing that we often have to make these kinds of prudential decisions where there's not some nice, easy formula. So let's have an example, right? Let's say I, God forbid, get in an accident on the way home, severely injured. I need to be put on a ventilator, the doctors determine, to keep me alive and stable long enough so that I can recover. Now, to the best of my knowledge, I am otherwise healthy, middle-aged man with a perspective of a number of decades of life ahead of me. And so in this sort of situation, putting me on a ventilator with the possibility of a real meaningful recovery from my injuries would be ordinary care, right? This would be morally obligatory. Yes, ventilators are uncomfortable and painful, and it's expensive to keep people in those sorts of care settings, but there is a very clear, discernible benefit that is likely to come from this. Now, it's a very different situation, say, when a very elderly patient who has been battling a range of chronic illnesses for a long time and is in stage, and whatever the disease might be, heart disease or cancer, what have you, and doctors determine that they are not breathing adequately anymore, and the question is whether or not we should put this person on a ventilator. In that sort of situation, there may be a benefit, right? There may be, this will keep this person alive a few more days, or maybe this will even keep this person alive a few more weeks. But the quality of life is not going to be good, right? There is no discernible benefit that at some point this person is going to meaningfully recover and be able to lead a flourishing life moving forward. This is going to probably be a continuous level of intensive care for the remainder of this person's very ill life. And in that case, that same treatment, being put on a ventilator, could very well be determined to be extraordinary care, right? That this is not morally obligatory. And in fact, the patient, ideally in consultation with family and friends and clergy, can determine that they do not want to be put on a ventilator to prolong their life. And in that case, there is nothing immoral being done, right? That a person can forego extraordinary medical care and simply allow a natural death to progress, and there's nothing immoral about that. And the same can be true for the removal of care, right? So if a person is put on a ventilator or put on some other kind of intensive or invasive medical treatment, it can be morally permissible to end or remove that treatment if it is determined to be extraordinary care, right? That the benefits don't clearly balance or outweigh the costs and pains and sufferings associated with the treatment. Now, there are going to be situations, obviously, that are more complicated than that, right? So it's not always the case of, a 19-year-old who's going to fully recover versus a decrepit 98-year-old who's only going to live a few more days strung up to lots of machines. Right? Obviously, there are going to be cases that are much more difficult to decide. But this is one area where, of course, informed consent is going to be important, right? That doctors need to tell the patient as clearly as they can what the various foreseeable costs, side effects, suffering are going to be from a treatment, and what potential benefits they can expect. And then, of course, the patient ought to have self-determination, be able to determine whether or not they want to receive a particular type of treatment. And again, if they're not able to, caretakers and family ought to strive to follow what would be their wishes as well as they possibly can. So again, admittedly, there are going to be cases where it can be very difficult to determine whether or not care is ordinary or extraordinary. Although in general, I think, from just personal experience and from talking to different doctors and nurses who've gone through a range of courses I've taught, I think in general our society tends to err on the side of more care, right, of continuing extraordinary care when not only is it not morally obligatory, but when it is also not really conducive to the flourishing of patients, family, and others. And that, again, we tend as a society, I think, to use medical treatments because they are available and not really think about whether or not these are really for the best for the person. And we probably all have experiences like this, where people have been kept alive in our families or friends for long periods of time with very intensive medical care in ways that don't really necessarily show any real benefit. Now, one of the things to make sure we're clear on here is extraordinary care is not morally obligatory, but it is morally permissible, right? So that if someone decides that they really want to fight to the bitter end to get a few more days, then that can certainly be morally acceptable. And people may have various reasons for doing that, whether they want to live to have a chance to reconcile with a family member or to reach a certain particular date that is important to them. There can be any number of reasons. But extraordinary care can be morally permissible to provide, it's just not morally obligatory. Right? So if a person decides they want to continue chemotherapy or dialysis or whatever it may be, even though the chances of it being successful are very slim, that can be a moral choice for people. But again, I think one of the things that there's a real need for in our society, and I think we see this starting to happen more with greater acceptance of hospice care, greater questioning even within certain areas in the medical field of whether or not we ought to be doing all of the intensive, invasive treatment that we do, particularly for very ill people near the end of their lives. I think that's a positive development, right? Now, I think one of the challenges and one of the things I would really hope that you would take from this class as people who are, in many cases, going to be teaching in churches or in schools, right, is to get people to recognize that this is not giving in to the culture of death, right? There are many Catholics out there who are under the impression, for whatever reason, that they have a moral obligation to prolong life as long as possible. And that has never been the Church's teaching, right? It's never permissible to end a life intentionally, but it is morally permissible in many cases to allow natural death to occur. So we don't have a moral obligation to keep people on life support to the bitter end. And it is not giving in to the culture of death to remove life support from someone who is not really benefiting from it. And in fact, that can be a recognition of the Catholic understanding of the person, right? That this life, as we're currently experiencing it, is not all there is. That there is something beyond this life. And also the recognition that it's not just bodily health that constitutes the good of a person. Their emotional well-being, their spiritual well-being, their relationships with others, all of those constitute the good of a person as well, right? And there are many people who have a very real and I think legitimate fear of how they might die, right? That there are many people who don't want to die in a hospital room hooked up to a million machines and wires and tubes. And again, I think this is part of the growing acceptance of hospice care, where people can die in more natural settings, in many cases even in their own homes where they are comfortable. Might they die a few hours or a few days sooner? Perhaps. But in many cases, that is going to be a more flourishing end of life than a longer dying process in a very discomforting, alien environment. If you have the time and opportunity, I would recommend very much a story by the author and essayist Wendell Berry. He wrote a whole series of novels and stories about a fictional small town in Kentucky. But he has a story called Fidelity, which is about this old grizzled mountain man, a burly coulter, who spent his whole life, traipsing around the hills and trapping things and living in a cabin and doing all of that kinds of good old backwoods living. A very colorful character. And then he comes down with cancer at the end of his life, and he gets taken into the doctor and gets checked into a hospital. And so you have this man who is practically one with his forest, with his cabin, and all those things. And he ends up in this hospital room with these tubes and the sterile sheets and all of that. And he's not only very sick physically, but this is extremely distressing to him emotionally and spiritually. And in the story, not to give away too much, but his friends and relations conspire basically to kidnap him out of the hospital, and they go and hide him in the woods so that he's going to be able to meet his end in a cabin in the woods where he belongs. I think it's a beautiful story. I highly recommend it. I can't assign it because it's like 90 pages long. But I think it captures very nicely this idea of, when we're talking about ordinary and extraordinary care, thinking about the end of life, that there is much more to the end of life and to life than keeping a heart pumping or keeping a biological life going as long as possible. So I would certainly encourage you to take that message and to share it in whatever context you're in, because I've encountered so many people who think that if they remove the ventilator, if they remove the life support from their loved one, that they are violating church teaching. And unless there's a very clear, discernible benefit that this is ordinary care, in most of the cases I've heard of, and in every case I've talked to someone personally about, it is in fact extraordinary care and is perfectly morally acceptable to remove that treatment. So I'd encourage you to make sure that the people you talk with are aware of that aspect of Catholic teaching. There is also a more specific issue when it comes to end-of-life care, when it comes to artificial nutrition and hydration, that is providing people with food and water, or as it is in modern medical contexts, perhaps a saline drip and a tube going into their stomach with glucose or some other kind of basic nutrients. And we will talk in another module specifically about the moral issues surrounding artificial nutrition and hydration, because there are some more complicated issues that arise there. But we're not going to address that here at the moment. What I want to talk about here briefly before we conclude this module is care for the body after death, right? And this is a important issue from a Catholic ethical perspective as well, both in terms of natural law and also in terms of Catholic teaching and tradition in general, right? Because one of the corporal works of mercy is care for the dead, right? It is one of the things that we do to kind of really image Christ in our lives by carrying out these bodily, corporal works of mercy for others. One of my favorite books in the Bible, the book of Tobit, centers on this in a Jewish context, right? The importance of care for the bodies of the dead. Now, again, there's a lot involved in this and a big tradition here that we can only touch on briefly. But of course, a dead body is not a human person in the full sense any longer, right? Because the person is the combination of body and soul. And in the case of a dead body, the soul is no longer present to that body in the way it is while we are alive, and the way it will be again in the resurrection. But that being said, it's not a person, but it is in some ways representative of a person. It is an aspect of a person that remains here. And so it deserves a great deal of respect, right? So we ought to treat bodies with dignity and respect. And again, we can get this kind of inversely when we think about how outraged we feel when people don't do this, right? When bodies are disrespected, pretty much universally in any culture, this prompts a great deal of outrage, right? So in ancient Greece, right, Antigone, the kind of classic Greek tragedy centers on this issue, right, of a king's refusal to allow the proper burial of someone. Or even much more recently, part of why the U.S. got involved militarily in Somalia several decades ago was because U.S. troops who had been there, their bodies were dragged through the streets and violated, and that was filmed and broadcast, and that understandably prompted a great deal of outrage from Americans that resulted in military action, right? So we have this innate sense that we ought to respect bodies. So how does this become relevant for us apart from, say, contributing to charities that provide for the burial of the poor? Well, in medical context, right, this becomes important in several different ways. Right, now, one issue here, sort of related to medicine, is the creation of these bodies exhibits, right? And probably most of you have heard of this, but there are several different exhibits traveling around museums across the country, around the world, where they take human bodies and they plastinate them, right? They inject them with all kinds of plastics and polymers and such, and basically create this sort of plastic mummification process where actual human bodies are then put on display in the museums in varying degrees of dissection, and in many cases they of course will pose these bodies in all sorts of everyday activities, or in some cases humorous activities. Presumably, the idea here is to provide education about the body and how the body works and how the body is put together. And I used to spend a fair bit of time talking about this, but it became my experience after teaching this a few times that practically everyone agreed that this really isn't in keeping with Catholic ethics, right? That there can be a proper use of bodies for educational purposes, right? So there's nothing immoral about the use of cadavers in medical school or in the training of people for medical professions. I've taught a class with an anatomist here at Newman where, in fact, the students weren't involved in an actual dissection, but they were shown cadavers and different dissections that had been performed as part of the educational process for these students. And one of the reasons the other professor wanted to teach this class was to emphasize to these students who were mostly going into different medical fields the importance of respecting these bodies and treating them properly. And so for real educational purposes, There's no ethical issue there, as long as the bodies are treated with respect. And if you know anyone who's been through medical school, you probably heard stories about different jokes and things going on in anatomy labs, and that would not be in keeping with Catholic teaching, right? That we don't use the bodies of the dead to scare classmates or to play jokes. Now, those are real educational purposes. The bodies used in exhibits at science museums or children's museums or what have you, there the educational benefit is much more dubious. It could probably be attained through the use of non-actual bodies, right? That you could come up with plastic replicas that would provide very much the same experience. And the fact that in most cases that I've seen, the bodies are put in purposely sensational poses would indicate to me that there's more entertainment here than education. And in that case, I think the use of bodies would clearly violate Catholic ethics in that case. So that would be one thing to address in terms of the treatment of bodies from a Catholic perspective. A more interesting case, I think, is the issue of organ donation. And organ donation presents some challenges, I think, for a Catholic ethical perspective. Now, on the one hand, we should say that organ donation is seen by the Church as a good thing. It has been referred to in magisterial documents as a very noble thing and a good sacrifice that people are willing to make. However, I think there's been some interesting challenges raised about the way organ donation is handled by different ethicists. And so one in particular, Gilbert Meilander, who's not Catholic, I believe. I think he's actually Lutheran. But he has talked a lot about the ethics of organ transplants and has raised some real questions about it. Now, if we're going to look at it in terms of principle of double effect, we can make, I think, a case for, yes, organ transplants are good and moral, right? That there's a definite benefit, the restored function or life of a person receiving an organ, but there is also a bad effect, right? So one bad effect would be sort of the violation of the dignity of the body, right? That a body is not left intact. At the moment of death, there's often a very flurried medical activity going on. And I think we would recognize the ability to have a peaceful death surrounded by friends and family, for the body to be kept in a state of respect and repose would be good things, right? So the absence of those things is a loss. Now, I think we can argue that using double effect, the benefits gained are proportionate and allow for organ donation. But we still need to, one of Meilander's points is we need to acknowledge that there is a loss involved here as well, and that it changes the nature of the dying process in important ways. And he also points out the fact that it does open up the possibility of abuse, right? That you can set up a situation where doctors see patients at the end of their life, not so much as a patient who is dying, but as a potential donor. And that this can change the nature of that person's treatment. And even if it doesn't explicitly lead to different actions towards the patient, it can certainly change the character of their care. And it can certainly be a very different dying experience. So Meilander would raise questions about organ donation in that regard. And then also in connection with some of the larger issues, right? In many cases, organ donation is very expensive, and the benefits in some cases are not very clear. Many people are not going to lead long or flourishing lives after receiving a donated organ. And so he argues that perhaps we have allowed the possibility of doing these organ donations to cloud our judgment about whether or not this is really good, proportionate use of our medical system. And so again, I will give you an article by him raising some of these questions for you to consider. And again, to reiterate, the Catholic Church teaches that organ donation is a good thing. But I think he does raise some questions worth considering, and whether or not the way we procure organs in our country and the way organ donation is handled has some bad effects that we don't really think about enough. And maybe there are things we could do to mitigate some of those bad effects while still making use of organs to really improve people's lives. So, anyways, we will leave that for now. We've covered a lot of ground, from basic medical ethics to euthanasia to ordinary versus extraordinary care to organ donation. So there's a lot of material to cover here. I will post some questions for you on Blackboard, but please feel free to raise your own questions on the discussion board as well, because there's a lot of important stuff to talk about here. All right, well, thank you very much.